Screen share.
Greetings and a very warm welcome to all the dignitaries present here. I'm Shwastika from Team Clarnit, serving as the allocated session assistant to ensure the seamless experience. Clarnit, serving as the allocated session assistant, is proudly stands as a digital uh, India's most relied upon digital platform, offering a multitude of imaging services exclusively for doctors. It is with great delight Clarnit serves as a digital partner for this event hosted by Indian College of Anesthesiologists. And the focus of today's session is ICCON. And now I would like to invite Dr. Rachna Bhutani ma'am to take over. Over to you, ma'am.
Good evening, everyone. I would like to first thank ICA for giving us this opportunity. Special thanks to Dr. Sood ma'am. Today's topic for today's webinar is neuroanesthesia, and the topic is mastering scalp block for awake craniotomy. Awake craniotomy is getting very important. It is very important because there are many procedures which are being increasingly done under when the patient is awake. So we have three topics for the three topics. We'll be talking in detail about the scalp block. First is Rudrashish Haldar. Your introduction CV slide, please. He'll be talking about introduction of the scalp block, its indications and method of block. Rudrashish, he is additional professor at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. His areas of interest are neuroanesthesia, pediatric anesthesia, simulation training, and he has more than 100 publications in PubMed, Index, national and international journals. He has written 4 book chapters. He is an awardee of KPR Young Anesthesiologist Award 2017 and Dr. Anil Agarwal Best Researcher Award in 2023. So, Dr. Rudrashish, please start.
Thank you, ma'am. Thanks a lot for the kind introduction. Good evening, everybody. As we know that the topic for today's webinar is mastering scalp blocks for awake craniotomy. The allotted portion on which I'll be talking about introduction to awake craniotomy and scalp block and the indication and methods of scalp block. I'll begin with a disclaimer from my end that this presentation contains certain videographic description of a particular patient, and for the demonstration of the same, we have obtained written and informed consent from the same patient prior to using his graphic images. Just a moment. So in the next 20 minutes or so, I'll be talking about basics of awake craniotomy, introduction to scalp block, and the methods of individual nerve blocks. By definition, awake craniotomy is defined as a procedure where the patient is awake during the critical portions of the brain surgery so that his vital functions, such as speech and movement, can be monitored continuously. If we delve down into our history, both European and South American, there are a lot many medieval pictures which shows that awake craniotomy, or rather trephination surgeries, were being done. Specialized instruments were there, and they were done in all the in more or less the civilizations of Europe as well as Central and Southern America. It will be safe to say that anesthesia in those days was absent or at the most rudimentary. So we can somehow hypothesize that yes, those were the earliest versions of awake craniotomy. And we can also assume that awake craniotomies were one of the first surgical procedures which were performed on humankind. In the near history, it was Sir Victor Horsley who performed the first awake craniotomy in 1886 to localize the epileptic focus with cortical electrical stimulation. Coming to the indications of awake craniotomy, if we divide them on the basis of anatomical, physiological, and pharmacological parameters, anatomically, it is conducted on patients who have tumors adjacent to their eloquent region or motor cortex of the brain. Physiologically, for certain procedures like deep brain stimulation or thalamotomy for Parkinsonism. And pharmacological indications include avoidance of drugs in conditions like brain mapping or electrocorticography. Specifically, the surgeries are those where mapping and resection of lesions in or adjacent to the eloquent areas of brain are conducted. For example, motor cortex, which is the Brodmann area 4, sensory cortex, that is the Brodmann area 3, 1, and 2, and the language cortex, that is Broca's and the Wernicke's areas. Then indications like identification and resection of epileptic foci, deep brain simulation surgery, stereotactic brain biopsies and ventriculostomy, and interventional pain procedures like pallidotomy and thalamotomy. Now, the question is, why do we actually require awake craniotomy? What is the need? The need is that we need to perform functional monitoring in certain conditions of the brain intraoperatively. And when I say functional monitoring, I mean that assessment of speech, assessment of memory, which may be immediate or delayed, association and pattern discrimination of words and pictures, voluntary motor movements and muscle strength, and of course, procedures like electrocorticography or electromyography, which we had already talked about. Now, there are certain advantages of awake craniotomy, which this procedure confers to us. First is that it maximizes tumor resection while preserving the neurological functions, avoids the risk inherent to general anesthesia and mechanical ventilation. Patients they have reduced requirement for ICU monitoring after surgeries. Neurological deficits are lesser, which translates into shorter hospital stays and early discharge. Decreased postoperative pain, nausea, and vomiting because of lesser use of drugs. Longer opioid-free period. Emergence hypertension is negligible. And as the total hospital stay is less, it translates into decreased nosocomial infection and decreased chances of, and as the patient can ambulate earlier, there is decreased chances of thromboembolism. Having said that, there are certain contraindications which may be absolute or relative, absolute being patient refusal, patients who are grossly confused, disoriented, or unable to cooperate and obey commands. Relatively, yes, patients having difficult airway, especially morbid obesity, OSA patients, having significant dysphagia or motor weakness, those who are unable to lie still, having orthopnea, certain surgeries where the size of the tumor or the tumor vascularity is very high, there is proximity to the vessels or significant dural involvement is present, patients who are claustrophobic or extremely anxious, and those who are suffering from uncontrollable coughing or hypertension. Now, coming to the goals of the surgery, once a patient has been taken for awake craniotomy, the goals include that sedating the patient in such a way that they are comfortable throughout the procedure. Hemodynamic stability has to be maintained, and adequate analgesia and anxiolysis for the entire duration of the surgery, which can stretch from 4 to 6 hours, has to be accorded to the patient. Now, while preparing for an awake craniotomy, the first and the foremost thing which has to be drilled in the mind is that it's essentially a teamwork between the neurosurgeons, neuroanesthesiologist, and the neurophysiologist. So this essential teamwork is the cornerstone for performance of a successful awake craniotomy. Another thing which has to be borne in mind is that the patient selection has to be very meticulous. Let me be very honest on this point that patient selection for awake craniotomy should be done very judiciously, as not all patients are good candidates for awake craniotomy. The patient should be well motivated, mature, calm, and able to tolerate still lying for a considerable duration of time. Not only that, he should be able to cooperate during testing phases, So we have exceptions like small children, decreased level of consciousness, patients with profound confusion, mental retardation, or having severe language barriers. Having said that, there are certain contradicting indications which we had already talked about, like patients having uncontrollable cough, those having anticipated difficult airway, those having obstructive sleep apnea, those having joint deformities or arthritis, which prevents them from lying still for long duration. These patients should not be taken up for awake craniotomy. Pre-anesthetic evaluation, of course, is important, but here in awake craniotomy, it assumes much more priority because it helps us to establish a good rapport with the patient. We get time to explain the procedure to the patient so that the patient feels comfortable during the intraoperative period. And in addition to the medical optimization, psychological optimization of the patient is also performed when we do a thorough pre-anesthetic evaluation. Need for counseling in this patient is paramount. This is because if we look from the patient's perspective, the patient has anxiety and fear due to the background illness. When the patient is undergoing surgery, there are terrifying noises of the drills, osteotomes, and the OT staff talking. Patient himself or herself is immobile and without any control of the situation. And this all translates into a feeling of helplessness. So this is where a psychological support with good personal rapport with the patient is very important. The patient should be explained beforehand regarding the pain during the local anesthetic infiltration, about the noises of the drill, and the various tests which might be required during the procedure, like writing, reading, fine movement, and also the slim possibilities of adverse events happening. Now, once we are counseling the patient, there are certain things which we need to stress upon to the patient is that patients can be afforded the best possible margin of resection. And when they undergo this procedure, there is a minimum possibility of postoperative neurological deficit. It translates into higher patient satisfaction, lower pain scores are observed, and there is less degree of postoperative nausea and vomiting. This is how the counseling sessions are conducted in our institute. This is something which we accord very high priority because patients who are selected for awake craniotomy are taken for minimum 3 counseling sessions where we stress upon the important points to the patients about awake craniotomy. Not only that, they are taken inside the OT for a tour so that they familiarize themselves with the surrounding, and their anxiety levels, their psychological motivation levels are adequately addressed. And we have seen that, yes, it actually has a tremendous impact on the success of this procedure. So this is something which has to be done very uh, 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 this is something which needs to be stressed upon throughout this procedure. Now, this is how the theater preparation is. The patient in the center of the OT, the anesthesiologist and the neuropsychologist are at the foot end, and the surgeon is at the head end, as is the general layout of a neurosurgical OT. In addition to that, certain important factors like the room should be quiet, the temperature should be optimum because the patient is awake, so he should not feel too hot or too cold. Everyone in the room should be aware that the patient is awake, so the decibel levels and the choice of words should be appropriate. Conversation should be as less as possible. Airway devices, local anesthetics, sedatives, everything should be ready. And the entire team should be prepared for any emergency which might strike any moment. Now, coming to the evolution of scalp block, The scalp block is an important armamentarium for the anesthesiologist while performing an awake craniotomy. This was first described by Gerwin, and this targets the major nerves innervating the scalp, provides intraoperative analgesia for a considerable period, and also provides potential for pain relief. The major advantage of scalp block is that it targets specific superficial sensory branches. Hence, chances of nerve injury is low as compared to deep motor nerves, and motor block is also absent. Now, these are the main nerves which are targeted while performing a scalp block. These include the supratrochlear, supraorbital, zygomaticotemporal, greater auricular, lesser occipital, and the greater occipital nerve. Now, coming to the individual nerve, as we can see that the supraorbital and the supratrochlear nerve, they have a common point of origin from the supratrochlear notch, and their region of distribution almost coincide. They are also blocked from a single point injection, which is injected after palpating the supratrochlear nerve and then extending medially, blocking both the nerves as is shown in this video. Next in line, we have the zygomaticotemporal nerve, whose region of distribution is shown. Here, we target the zygomaticotemporal groove, and once we encounter it with the needle, we fan it along the entire course of the nerve. This is where the zygomaticotemporal groove is being encountered. Once we encounter, we withdraw a bit and fan around 2 to 3 ml of local anesthetics. Next, we have the auriculotemporal nerve. The specialty of this nerve is that it lies just in front of the tragus and posterior to the facial nerve. And the landmark for identifying this nerve is the pulsation of the facial nerve. This is one of these areas where we need to be very cautious because there is high chances of inadvertent intra-articular injection of local anesthetics. So this is where ultrasound can also prove helpful, as will be dealt in the later half of the webinar. Now, as we see that the facial nerve pulsation is appreciated and the puncture is made just posterior to the pulsation. Once the temporal bone is encountered, aspiration is done, some amount of local anesthetic is injected, and then the needle is withdrawn as is being done now beyond the temporalis fascia, and rest of the local anesthetic is deposited above the temporalis fascia. Next, we have the greater and the lesser occipital nerve. They are identified, as we can see in this figure, by drawing a line connecting the occipital protuberance with the mastoid process and then dividing it into 3 equal parts. The one in the lateral part shows the passage of the lesser occipital nerve, and the medial one shows the site for the greater occipital nerve. This is where the lesser occipital nerve is being blocked. And this is the greater occipital nerve being blocked. Now, once the block has been administered properly and it has been allowed to set in, which takes around 15 to 20 minutes, we can see that even during pin fixation, which, as we all know, is an intensely noxious procedure where there is a sudden surge of hemodynamics and sympathetic overshoot, we find that if the block has been placed properly, vital parameters during this procedure remains extremely controllable. This is the patient who had been adequately sedated and uh, a scalp block has been administered for a considerable period of time, say 15 to 20 minutes. This is the baseline vital before pin fixation has taken place. Now the procedure of pin fixation has started. Usually this is the period when there is a overshoot of blood pressure and heart rate. But what we see here that in this patient, they remain very stable even during this period. This is the beauty of a properly placed scalp block, which has been given adequate time to act. That is how an appropriate block should be. That's all from my end. From here on, Dr. Ashish Kannaujia will take over. Thank you.
Thank you, Dr. Rudrashish. It was a very well presented talk on awake craniotomy procedures, how are the blocks given. So thank you once again, and we will take the questions at the end of the session. I would now like to call upon Dr. Ashish Kannaujia, who uh, who is a professor at Sanjay Gandhi Postgraduate Institute of Medical Science, Lucknow again. And his areas of interest are regional anesthesia, airway management, medical technology, medical innovation, and development and designing of medical devices. So he has got a very innovative mind. He has got more than 56 publications and book chapters, 15 patents on his name, and the Appreciation Award from President of India for Smartphone Video Laryngoscope, facilitations and awards from Vice Chancellors of AGMU, got ISA Innovation Award for last 4 years, and he has been awarded by SGPJ President Award for a maximum number of patents. Besides that, Best Research Paper Award on Research by SGPGI MS. So over to Dr. Kannaujia. He will be talking on drug combinations for scalp block and intraoperative complications with management. Dr. Ashish, you can take over, please.
Yeah, good evening, everyone. Let me share my screen.
Hello.
Hello. Hello.
I think Dr. Ashish is having problem with
Yeah,
screen.
there is some issue with the sharing.
Mm-hmm.
Now, just give us a couple of minutes. We'll just sort it out. Just give me a moment.
Okay, all right, sure.
Ma'am, I think we got it. Just give me a moment. I'll share it.
Please go ahead. Okay.
Hello. Hello.
Yes, Dr. Kannaujia, we can hear you.
Yeah, sorry for the technical glitch. So, good evening, everyone. The previous speaker has beautifully covered the basics of awake craniotomy and individual scalp block, individual nerves which are blocked in the scalp block. In this presentation, I will try to cover the drugs, techniques, complications, and how those complications are managed during awake craniotomy. So, awake craniotomy allows to preserve brain function during tumor resection, and the scalp block is backbone for awake craniotomy. Unlike general anesthesia, this approach lets patient to cooperate during brain mapping, and we can imagine it as hitting pause when the surgeon needs feedback from the patient. So our goal is to avoid damaging critical brain regions while the patient is awake and responsive. It's like performing brain surgery under live GPS, that is taking feedback from the patient, and patient is guiding us for the resection, optimal resection. So there are some pictures or sketches which are taken from internet, and I do not endorse any brand or trademark. It contains a video of a patient whose consent has been taken for demonstration. So in awake craniotomy, the patient remains awake during critical part of surgery so that optimal excision of lesion can be done with the feedback provided by the patient, and to enable patient to remain pain-free without heavy sedation so that patient remains cooperative and responsive. Patient selection and counseling is most important, as Dr. Rudrashish has also emphasized, and it is the most important thing for success. And next thing is a good scalp block and proper anxiolysis and sedation for patient comfort and cooperation. So awake craniotomy can be done under infiltration, which used to be done before scalp block has arrived. That is infiltration at the pin insertion sites along the surgical incision and dural infiltration before opening the dura. But after the introduction of a scalp block, infiltration is rarely used. It's used mostly for the supplementation, and scalp block makes the standard of care for awake craniotomies. So during awake craniotomy, patient needs close monitoring, and the monitors include standard ASA monitors, which includes ECG, saturation, non-invasive blood pressure, capnography, and temperature. And depending on patient's coexisting conditions, intraarterial line can be inserted, which provides not only beat to beat blood pressure recording, but also enables us to do arterial blood gas analysis. And central venous catheter can also be placed, especially in patients where surgery has to be done in sitting position, where chances of venous air embolism are more, or there are chances of excessive bleeding. And there are some specific monitors which are used for depth of anesthesia monitoring, like BIS monitor. Foley's catheter can be done as the procedure is of long duration and full bladder can cause agitation. And many times, due to tight brain, administration of osmotic diuretics are used, which needs emptying of bladder. So depth of anesthesia can be monitored by BIS or entropy, whichever is available. In BIS, we target around 60 during sleep phase and more than 85 during awake phase. If those monitors are not available, then we can do modified Ramsay sedation scale. And neuromonitoring in brain mapping is done for the assessment of vision, speech, and power. So brain mapping was originally used for epileptic surgeries, but now utilized for tumor resection also, and more widely used within last 2 decades. Intraoperative brain mapping is done quite frequently nowadays. It is done for mapping for language like Broca's area and Wernicke's area. Then mapping for motor function, direct electrical stimulation of cortex is done to elicit motor movement, and motor evoked potentials are used to map and monitor subcortical motor pathways. This table summarizes the different monitors used in awake craniotomy in different type of patients. Like for epilepsy surgery, EEG monitoring and electrocardiography is done. And likewise, optimal monitor can be selected according to the type of surgery. So the nerves which supply scalp need to be blocked, and nowadays mostly long-acting local anesthetics are used like bupivacaine, levobupivacaine, and ropivacaine. These drugs are used alone or with adjuvants to prolong the duration. And since scalp block is a high volume block and it requires around 30 to 40 ml of local anesthetic for infiltration, so a maximum dose should be calculated and it should not exceed, because scalp is a highly vascular area. So there are chances of local anesthetic systemic toxicity. And to reduce the chances of last, careful aspiration before each injection and addition of adrenaline in 1:2 lakh concentration is useful and decreases the chances of local anesthetic systemic toxicity. This table showing comparative properties of most commonly used local anesthetics and taking into considerations all the comparative points. Levobupivacaine is better choice for the scalp block as it has long duration of around 4 to 8 or 5 to 8 hours, which is comparable to levobupivacaine, but it is with better safety profile in terms of cardiac and neurotoxicity. However, due to wide availability and low cost, bupivacaine remains the most commonly used drug for scalp block. There are different adjuvants which have been used with local anesthetics for scalp block. The commonly used adjuvants are shown on the screen. These are added to prolong the duration and make the block more intense. Epinephrine is frequently used at it increases the duration, decreases the rate of absorption, and also reduces the bleeding during incision of and flap of the scalp. The other adjuvants which are used are dexmedetomidine and clonidine and dexamethasone. Dexmedetomidine reduces the requirement of doses of sedative and provides analgesia also. So in this table, different adjuvants have been compared, and amongst these adjuvants, adrenaline, dexamethasone, and dexmedetomidine have been most studied drugs. So nowadays there are studies coming where ultrasound guided scalp block is being performed, and in this table we can see the comparison between the two. Though traditionally scalp block is performed with the landmark technique, which is easy to perform and easy to learn, but it may result in incomplete block, resulting in variable success, whereas ultrasound guided block requires training and experience and ultrasound machine, but has better block success rate and lesser chances of complications at the cost of increased time for performing block. In ultrasound guided block, there is requirement of lesser amount of drug, so chances of local anesthetic systemic toxicity is also reduced. So other than local anesthetics, we require to sedate the patient for the patient's comfort. So dexmedetomidine is most commonly used drug nowadays for this purpose. This is a selective alpha-2 adrenoceptor drug. It provides sedation, anxiolysis, and analgesia, and it doesn't cause respiratory depression, and patient remains responsive. It requires a loading dose at the rate of 1 microgram per kg, slow IV over 15 to 20 minutes, followed by infusion at the rate of 0.2 to 0.7 microgram per kg per hour. But caution must be taken during loading, as fast administration should be avoided, which can lead to bradycardia. So propofol is another drug which is popular in awake craniotomy due to its easy titratability. It's a rapid recovery. It reduces intracranial pressure. It has antiemetic properties, but its use is decreasing after availability of dexmedetomidine due to higher chances of respiratory depression, loss of airway, loss of responsiveness, and more chances of hypotension. So it's better given with target controlled infusion pump whenever possible, and usually it is given along with some opioid like fentanyl or remifentanil. The combination of propofol and remifentanil is ideal one. And usual dose required is 50 to 150 microgram per kg per minute. So fentanyl can be given for supplementation of block or after the effect of block has receded as a part of multimodal analgesia or as a rescue analgesia in small boluses or as continuous infusion. Remifentanil is an ultra short acting opioid which is becoming very popular. Now it's available in India also, but it's not available widely. At some centers it is available. It has a rapid onset of action and offset of action. It has a half context sensitive half life of around 4 minutes, due to which patient awakens rapidly and neurological testing can be done. It is used as infusion in the doses of 0.05 to 0.1 microgram per kg per minute, or it's better to use it with target controlled infusion if available. So coming to anesthesia techniques, for awake craniotomy, there are mainly two techniques. One is sleep awake sleep technique, or also known as asleep awake asleep technique, and other is awake 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 technique. So I will be discussing one by one. So in sleep awake sleep technique, there are three phases. First phase is GA is induced mostly with the supraglottic airway device, and then the brain is opened, and in the second phase anesthetics are discontinued. Patient is allowed to take spontaneous breathing, and once patient awakens for functional and electrophysiological testing. Once this testing is and mapping is done, the GA is induced again, similar to the first phase, and the rest of the procedure is continued. Next comes awake 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 technique. It is relatively new concept and it's gaining popularity due to its advantages like less hemodynamic instability, less airway obstruction, less chances of hypoventilation, less nausea and vomiting. But it requires a properly counseled and highly motivated patient for the success of the technique. So mostly drugs which are used for awake technique are dexmedetomidine, low doses of propofol along with opioids. Our target is to keep the patient responsive to verbal and tactile stimulation. In this table, the two techniques have been compared. Both techniques have their own pros and cons. Nowadays, awake is gaining popularity due to availability of better drugs and lower risk of airway complications and more stable hemodynamics. But here patient we need a highly motivated patient. Then in this table, different sedative drugs has been compared for conscious sedation for the patient. The common drugs used for this purpose are given in the table. Nowadays, dexmedetomidine is most commonly used drug for sedation in awake craniotomy because of its ease of titratability, minimum respiratory depression, excellent patient interaction compared with the propofol, opioids, and benzodiazepines. So dexmedetomidine remains the excellent choice for awake craniotomy. Then coming to the complications of awake craniotomy, These may be related to anesthesia part or may be related to surgery. We can classify the complications according to organ specific, like related to respiratory, cardiovascular, neurological, or other. So along with these complications, patient have certain complaints, like patient may feel dry mouth, may feel nauseating, may feel cold, or may complain of shivering. So respiratory complications mostly are related to the sedation related issues. So if patient is over sedated, there may be loss of cooperation, patient may desaturate, there may be airway obstruction, and if patient is under sedated, patient may be anxious, agitated. So and if patient is over sedated, major problem is CO2 retention, which leads to brain bulging, resulting in difficulty in resection. Then there may be intraoperative seizure. To avoid intraoperative seizure, the patients who are on anti-epileptic, it should be continued till the day of surgery, and there should be adequate stock of IV anti-epileptics like phenytoin or fosphenytoin in the OR in case it is needed. The incidence of intraoperative seizure is around 2 to 21%, which is mostly focal and self-limiting once we ask the surgeon to stop stimulation. The risk factors are young individuals, patients with a history of seizure, and frontal lobe lesions. Immediate withdrawal of stimulation is the first step which has to be taken, and then iced saline or ringer lactate around 3 to 6 degrees centigrade should be poured on the cortical surface, and if it is not controlled, then propofol can be given. And usually benzodiazepines and phenytoins are avoided as these will interfere with the EEG if it is for epilepsy surgery. Then there may be intraoperative brain swelling, which may be due to CO2 retention leading to vasodilatation and underlying mass effect. Incidence is around 25% for glioma resections. And if it happens, corrective measures are verify patient's position, is there free venous drainage or not, administer osmotic agents, reduce sedative agents if patient is heavily sedated, try to wash out CO2, and in surgical considerations, large craniotomy to facilitate a more even distribution of edema. Then there may be chances of venous air embolism, mostly in upright position patients who are having spontaneous breathing, and patients having cough, dyspnea, or agitation or chest pain. Signs may be patient may complain of hypoxia, sudden decrease in end-tidal CO2. Patient may have hypotension depending on the severity of venous air embolism and ECG changes. The management is irrigation of surgical field, Trendelenburg position, 100% oxygen, and management of the hemodynamics. Neurological deficit may be there in 9 to 38% patient. Causes are subcortical tract injury, edema, and inflammation. And in most of the patients, gradual resolution is possible. Then patient might complain of nausea and vomiting. Uh, to avoid that, we should ensure nil oral guidelines as per ASA. Injection ranitidine should be given before taking up for the surgery. Injection ondansetron 0.1 to 0.2 milligram per kg IV along with dexamethasone 0.1 to 0.25 milligram per kg can be given. And then comes the local anesthetic systemic toxicity, and patient may present as seizure, or there may be a hemodynamic instability, bradycardia or tachycardia. Then first step is stop the LA injection, and mostly local anesthetic systemic toxicity happens within the 15 to 20 minutes after the scalp block. And then we have to give lipid emulsion and seizure control. So this is a very good flow chart given by NISORA for the management of local anesthetic systemic toxicity. The first step is call for help, and then start ventilatory support or oxygen, and should alert for cardiopulmonary resuscitation. And mainstay of last is lipid emulsion 20%. If patient is more than 70 kgs, then 100 ml bolus over 2 to 3 minutes is given. And if patient is less than 70 kgs, 1.5 ml per kg over 2 to 3 minutes is given. And such 2 to 3 boluses can be given followed by infusion at the rate of 200 to 250 ml over 15 to 20 minutes. If the condition doesn't improve, the bolus amount can be doubled. Then there are certain complications like formation of hematoma at the site of injection, which can be easily treated by applying direct pressure. Then if there is a block failure, supplemental local infiltration can be given, or a rescue analgesic in the form of opioid like fentanyl can be given. And if patient is over sedated, sedative drugs are reduced, oxygen is supplemented, and airway patency is ensured. Then in troubleshooting, patient might complain of anxiety, pain during surgery. So first thing should be we have to reassess the block, give supplemental local anesthetic if required, or IV opioids in the form of fentanyl can be given. If patient is having inadequate sedation, the sedative can be titrated. If patient is having hypertension or tachycardia, we should try to find out the cause, and we should not treat directly tachycardia or hypertension straight away with the beta blockers or labetalol. We should try to find out, and then like if patient is having pain, we should give opioids, and if it is not treated, then only we should go for beta blockers or labetalol. Then sometime patient complains thirst, so sips of water can be given. So in this video, it is shown during awake craniotomy how we monitor the motor. And then key takeaways are scalp block is essential for awake craniotomy success. Use of long-acting local anesthetic along with adjuvants for prolonged analgesia can be used. Monitor for local anesthetic systemic toxicity closely for initial 15 to 20 minutes after the block. And rescue plan must be ready to deal with the complications. Awake craniotomy requires proper selection of patient, a good rapport with the patient, adequate analgesia, correct method of examination of the areas involved, an alert neuroanesthesiologist, good intraoperative and postoperative analgesia, and follow-up of patient till the discharge. Thank you so much.
Thank you, Dr. Ashish, for such a elaborate discussion on awake craniotomy and in detail about the drugs used. Okay, our next speaker is Dr. Sumit Sachan. He'll be talking about the evidence-based revision of scalp block, current concepts and literature review. He is Associate Professor at SGPGI Lucknow. His areas of interest are neuroanesthesia, regional blocks, hemodynamic monitoring, and his publications and awards. He has 15 publications in national and international journals. He has written 3 book chapters, and he was awarded Best Research Paper at SGPGI Foundation Day in 2024. Dr. Sumit, please.
Audible now? So thank you so much, ma'am, for the kind introduction, and a very good evening to all the listeners. So in this previous brainstorming session of neuroanesthesiology entitled Mastering Scalp Blocks for Awake Craniotomy, the previous speakers have beautifully explained about the scalp block and the awake craniotomy, and I will be basically revising what all we have studied till now, but with an evidence. Moreover, I'll be talking about some of the current concepts and literature review. So before I begin, I have no conflicts of interest. What all the information that I'm providing is mainly based on the evidences that I have gone. And yes, there could be some slight differences that might be present depending on the available literatures and the literature that I have shown. So, Sir Ryan Ormond, in his article, The History of Neurosurgery and Its Evaluation, which is published in Neurosurgery Focus, he mainly talked about how the history of neurosurgery has been evolved, and he's described some of the brave surgeons who had performed surgeries during their great odds. So the brain was considered to be a black box, and from where to enter inside was a tough question. The Hippocratic school was the first to codify the treatment for head injuries by doing trepanations. The major changes in neurosurgeries came in the early 16th centuries once the concept of anesthesia, hemostasis, and antisepsis came. So wine and opium has been used for their sedative and analgesic effects till 16th century, which continued till 18th century. The local anesthetics techniques were pioneered by Halsted and Hall, who performed the nerve blocks in early 1880s. The term regional anesthesia was first introduced by American surgeons, Sir Harley Cushing, and later on he came up with the concept of peripheral nerve blocks for the scalp, in which is beautifully explained by Sir Alexander Pepin-Glue. This article came in the year 2011. Coming out to be historical aspects of some anesthetic agents. So cocaine was used initially by Hall in the year 1880s. Later on, the first synthetic ester local anesthetic procaine was developed by Enhorn in the year 1904. It was found to have shorter duration of action and has frequently associated with allergic reactions. Henrik Braun later on added epinephrine to the available local anesthetics at that time, and he found there has been increasing in the duration of local anesthetic effect. Things were continued till 1948 once the amide local anesthetic came into picture, that is lidocaine, and it has transformed the local anesthetics tremendously as the lidocaine got developed, obviously over the period of time. the use of peripheral nerve blocks has increased tremendously since then. Coming to the scalp block origin, so Girvin was the first person who described the scalp block based on the anatomically landmarks in the year 1986. He performed the scalp block in awake patients undergoing intracranial surgeries. And in his article, which got published in the International Anesthesiology Clinics in 1986, he emphasized more and more on the patient counseling and patient selection. At that time, he basically targeted five nerves. The three were three from the anterior region of the scalp and the two from the posterior region of the scalp. Sir Irene Osborne, in his review article, which is published in Journal of Neurosurgical Anesthesiology, he described how the block got evaluated through the ages. So, in the pre-general anesthesia era, a scalp block was performed to execute the intracranial procedures. However, its use declined once the general anesthesia came in picture. Later on, it was integrated with general anesthesia to reduce the intraoperative anesthetic requirements and to improve the hemodynamic stability. Over the period of time, there has been some refinements for the hemodynamic controls for getting more anatomical landmarks, target nerves, so that the hemodynamic response to incision and pin applications can be minimized. And in present era, where the choice of surgery as far as the neurosurgeons is concerned is minimally invasive, so it has been resurgence again as in awake craniotomy. Now, this was the first double-blind randomized study, which is published by Hillman in the year 1987, which is published in Anesthesiology Journal. He took 40 patients in which the 0.5% bupivacaine local anesthetics was compared with normal saline in scalp infiltrations, and the author compared the hemodynamic parameters in pre-induction, pre-incision, post-incisions, and post-procedures. And what he found was there is an increased cardiovascular hemodynamic stability in those patients where the bupivacaine infiltration was given. Later on, Hartley et al. Demonstrated similar results in children undergoing supratentorial craniotomy. Rubiel et al. In another study, which was done in 34 patients of intracranial masses undergoing craniotomy. He basically divided these 34 patients in three different groups. Group 1 received IV fentanyl before head fixation. Group 2 received subcutaneous infiltration of mevigaine. And in group 3, the frontal and occipital nerve blocks were administered. And what he found was in those patients in which the block was administered, they have got relatively stable hemodynamics. Coming out to the target nerve, so as described by the previous speakers, so we have got a supratrochlear, supraorbital, zygomatricotemporal, and auriculotemporal for anterior part of the scalp, whereas the nerves which supplies the posterior part of the scalp are greater auricular, lesser occipital, and greater occipital nerves. Third occipital nerves, yes, can be blocked, and it has come as a seventh nerve to be blocked by scalp block. Now, over the period of time, scalp block has been administered and it has been checked to assess the hemodynamic responses, and it has been done by various authors that has been using scalp block for different types of surgeries. And what they were using are the local anesthetic infiltrations in the form of bupivacaine with or without adrenaline. And it has been compared with local infiltrations or with normal saline. And what they have found that in those patients where the local anesthetic block was given, these patients have relatively better hemodynamic responses, not at the initial hours, but it lasts even for 24 hours, and some studies have even quoted even for 48 hours. Now, it has also been studied in acute and chronic pain by various authors in supra and intratentorial surgeries. Many as RCTs has been coming up and has already been there in the literature, in which the bupivacaine, ropivacaine was compared with IV fentanyl, morphine, with the normal saline, and with it is even compared with the infiltrations. And what they have found is, in those patients where the scalp block was given using bupivacaine or some of the adjuvants, so they have got a better pain scores in the post anesthesia care units, and they last even for 24 hours post operatively. Some of the authors have even quoted that the requirement of pain medications and NSAIDs has even reduced up to 14 days post surgery. Coming out to the scalp block techniques as described by the previous presenters. So there are mainly two techniques that is based on the different stages. One is sleep, awake, and sleep methods, and second is awake, awake, and awake. So in awake, awake, and awake method, it is mainly done by monitored anesthesia care or conscious sedations. So in the pre-awake stage, in a sleep stage, sleep awake sleep stages, and generally general anesthesia is administered during awake stage, where the neurophysiological monitoring, brain mapping, and tumor resection is done. In both the stages, patient is made awake. Whereas in post-awake stage, I, I mean, during closings, again, general anesthesia can be administered in sleep, awake, and sleep methods, whereas monitored anesthesia care is continued even in the post-awake stage. Now, this is one of the article by Chizili, which has been published in World Neurosurgery. This is basically a retrospective study of 81 patients where the awake craniotomy has been performed by a single surgeon and a single team of anesthesiologists. 50 patients were treated using MAC technique, whereas 31 patients were treated with sleep, awake, and sleep techniques. The authors mainly evaluated the intraoperative complications, post-op outcomes, pain management, and complications, and they have concluded that both MAC as well as the sleep awake sleep techniques for sedation, provided they are equally efficacious and safe methods for managing awake craniotomies. However, in those patients where the MAC technique was used, they have relatively shorter duration of operative time. This is another study by Sokal N and Raj GP, which has been published in Indian Journal of Anesthesiology. He is basically emphasized for conscious sedations, fentanyl, propofol, and dexmedetomidine. This is another article by Alexander Kulikev, Anesthesia for Awake Craniotomy, where the author have emphasized more on dexmedetomidine for conscious sedation. Now, another review article by Sir Paul J. Jetley, which is published in Anesthesia, Critical Care and Pain, which has come up in 2020. He's beautifully described the sonoanatomy of different nerves, scalp nerves that can be blocked using ultrasound. And what they have turned up that it is an easy method. It's better for the patient safety and requires lesser volume, thereby and as well it spares the nearby arteries as well. This is one of the studies which has been published by Sir Signing Zai, where the author have studied the use of scalp block in Parkinson's patients undergoing deep brain stimulation surgery, where he basically divides 74 patients in two different groups. One group was given traditional anesthesia, whereas another was given scalp block using 0.5% ropivacaine. And the authors have found that those patients in which the scalp block was administered, they have got a better patient pain levels, better patient satisfaction score, and has got fewer side effects. Now, some of the complications of the scalp blocks. Yes, scalp has innervated by usually high capillaries. So the chances of local anesthetic toxicity is relatively more in scalp blocks compared to other peripheral nerve blocks. So as the propensity of seizures, the literature has given the incidence of seizures that ranges between 3 to 6%. Hemodynamic instability, intraneural injections of the local anesthetic. Block failure has been seen in 2 to 3% of the patients where the general anesthesia has to be administered in those cases. Local anesthetic introduction into the subarachnoid space, it has been well written in the literature. Venous air embolism are some of the other complications. Some of the complications pertaining to scalp block self are intraoperative swelling, brain swelling, which has an incidence of around 20 to 25%. Unilateral complete ptosis of the scalp block, transient facial nerve, and even the orbital injury has even been shown in the literature. Now, this is one of the another systematic review and the meta-analysis which has been published by Sir Liu. It has come up in the October 2023, where the authors have included 24 randomized trial. Their primary inclusion was to check for the acute post-operative pain, and the secondary outcome was to assess the opioid consumptions. And what the authors have found is in those patients where scalp nerve block using ropivacaine or bupivacaine was given, they have got a better pain control and requirement of opioids was relatively less, and that even last for first 24 hours post-operatively. Now, coming out to the scale block in some special subsets. So, these are some of the review articles where the awake craniotomy has been performed in pediatric patients. So usually, the age group lies between 12 to 13 to 15 years of children has been taken by most of the authors. And what they have come up with that the awake craniotomies using scalp block has been performed, can be performed easily in pediatric age groups. However, one of the case report has even mentioned that awake craniotomy has been successfully performed in a 9-year-old child. Awake craniotomy in pregnant patient is another subset as it is associated with two live births. So this is one of the literature of Muhammad Mustase, which is published in Neurosurgical Review that has came up in November 2023. He's basically taken a literature review investigating awake craniotomies during pregnancy, and he took all the patients right from its inception of scalp block till February 2023, and he has talked about some of the 9 studies that has been taken under this review. Majority of them are the glioma surgeries involving frontal lobe. Awake was the approach that was followed in most of the procedures. Surgery durations in different studies that was found, and that was ranging from 2 hours to 9 hours. Intraoperative fetal monitoring was done in 7 out of 9 study, and none of the study got converted into general anesthesia. So they emphasized that awake craniotomy for resection of cranial lesions of eloquent areas in pregnant patient is safe and feasible and doesn't alter the pregnancy outcome. Scale block has been even performed in cases for the treatment of post-dural puncture headache, and this is one of the article of E. Matute, which has been published in Anesthesia, Perioperative Medicine and Critical Care, where 2 patients of PDPH has been successfully treated by 4 mils of 0.25% bupivacaine along with 20 milligram of triamcinolone. Coming out to some of the novel applications of scale block. So it has been performed in cases of aneurysm surgeries. Now the author Salim Abdullah in his article where he took almost 30 consecutive adult patients of unruptured intracranial aneurysms, and he found that out of these 30 patients, 3 patients, they developed neurological deteriorations at the time of temporary clipping. So he emphasizes that yes, in awake craniotomies during temporary clipping, there is a risk of ischemic injuries which can easily be detected if your patient is in awake position. Awake craniotomies for aliquot brain AVMs has been described in a review article which is published in the Word Neurosurgery that has come up recently in the March 2025. It has been published by Gabriel Samuel. And he also emphasized that awake craniotomies for aliquot AVM showed promising results and it should be considered if the patient is having AVM in the aliquot regions. It has even studied in cases of microvascular decompressions for trigeminal neuralgia, and this is one of the review article where Ariba Farid has described how awake neurosurgeries can be performed in cases of microvascular decompression, and it has got some promising results. Not only at the intraoperative, but definitely they have got a better results in the postoperative period as well. Some of the future things that of the scale blocks. So maybe we might be having some functional brain mapping that we might see in the near future. AI is artificial intelligence is getting impregnated everywhere. So we might see some artificial intelligence based mapping. Ultrasound guided scale block may be some standard of care in the near future. And definitely, we may come up with some long-acting local anesthetic agents like liposomal drugs. So take-home message, scale block is safe, effective, and evidence-supported. It can be done for critical surgeries using multimodal analgesia. It can be implemented in special population subsets. And definitely, we need more RCTs and standardization. Thank you so much.
Thank you, Dr. Sumit, for that excellent presentation and review of literature, highlighting importance of awake craniotomy not only for surgeries in eloquent area and epilepsy surgeries, which it used to be earlier, the expanding role of awake craniotomy in other surgeries as well. So that was a very, very uh, you know enlightening talk, and from all the three speakers. So can we take few questions which we have? So the first question which have, how much volume in each site is recommended in scalp block? What concentration of local anesthesia is recommended? So Dr. Rudrashish, will you like to take this?
Yes, sir. I will. Sir, am I audible, sir?
Yeah, you are.
Okay. The question is, how much volume in each site is recommended in scalp block, and what concentration of local
Probably you have
anesthetic
two
is
devices open and we are having the echo here. Can you mute the other device? Yeah. Yes. Yes, now you can.
Sir, there's still some amount of echo, I believe. Just a moment. How much volume in each site is recommended in scalp block? So, each site, when we talk about each site, it is recommended 2 to 3 milliliters, not more than that. And these being thin superficial sensory nerves, 2 to 3 milliliters at each site is sufficient. Now, coming to the concentration of local anesthetic, what we do in our practice is we actually mix lignocaine with ADR with either bupivacaine or ropivacaine. So the advantages of early onset as well as prolonged duration that is available when we use a mixture of drugs. And whatever may be the concentration which you are using, we'll have to bear in mind the single thing that we cannot exceed the toxic doses. And of course, they act cumulatively. So we first calculate the weight and the total safe dose which can be administered. And based on that, we formulate the mixture of lignocaine with adrenaline 2% and bupivacaine. And then at each site, 2 to 3 ml, not more than that. That is sufficient.
Absolutely well said. That's one thing, as Dr. Rudrashish has highlighted, that the toxic dose you have to bear in mind. You have to be well within those ranges. And as he has already highlighted, they mix in their practice. They mix, short acting with the long acting, like lignocaine with bupivacaine or ropivacaine. There are different practices by different people. Some may use directly only bupivacaine, but then they have to wait a little longer for the effect to come, as being highlighted in the talks also. Yes, uh, one each site, 2 to 3 ml, as we said, but with when we are getting specific using your ultrasound techniques, and where we know that we are right at the nerve, so even 0.5 to 1 ml or 2 ml is good enough. So total dose for each nerve, we don't exceed around more than 2 in that case. Right. Then there's another question: can the patient tolerate SAD when awake without coughing? So, Dr. Rudrashish, you can take, or if
So Dr. Ashish Kannaujia can.
Hello,
okay, yeah, please.
am I audible?
Yes, Dr. Ashish, carry on.
Am I audible?
Yeah, you are. You are audible. You are audible.
Hello.
You are audible. You can take.
Yeah. So your question is whether awake patient can tolerate a supraglottic airway device.
Yeah, that's the question from the
Yeah.
audience.
So no, it's not possible. If patient is awake or mildly sedated, patient cannot tolerate supraglottic airway device. That's why supraglottic airway device is used in asleep technique and not in awake technique. So to tolerate supraglottic airway device, we must uh, induce GA without muscle relaxant, of course, but without inducing GA, patient cannot tolerate supraglottic airway device.
Yes, so that is true, as Dr. Ashish has highlighted. So when we are using sleep, awake, asleep, so if you have used supraglottic device during a sleep state, but when while monitoring, we have to remove the device, because you are sometimes monitoring speech. So you have to remove the device for during that time. And later on, you may continue with MAC, or you may again reinsert the device and put back patient to sleep. So this is a practice in few centers. What is our practice, your practice, Dr. Ashi? Do you go for awake, asleep, or you go for awake, awake, awake?
Here we use awake technique
Right. So in
with
that case,
the
we don't
MAP
need to do
sedation
it.
with dexmedetomidine.
Absolutely. So that is
Yeah.
the better way, not better way, both are equally effective, but it's institutional practice. Some people go for asleep, and others go for awake, awake, awake technique. So only during GA, you have to introduce a supraglottic device. When you're monitoring, then you have to, and when you have to make the patient awake, you have to remove the device. That's
Yes, exactly.
right. So I could see only these two questions in the chat box as of now. Since we have few more minutes, um, uh, uh, Dr. Sumit probably talked about pediatric age, awake craniotomy in pediatric age group. So what is your experience in the pediatric age group, Dr. Sachan, if you can enlighten on it?
Uh, Sir, am I audible?
Yeah, you are.
Yes. So, majority of cases that I have done as far as the scalp block and awake craniotomy is concerns are adult patients. But yes, we have done some of the counseling sessions of around 15, 16-year-old child. Unfortunately, it could not be performed because the tumor size was quite large, and there was some problem with the patient cooperation. Even the literature has mentioned that the psychological support of the pediatric patient is much more important. So, and some of the literature has even talked about that you need multiple sessions. You will have to take the kit inside the OT just to familiarize the OTs and everything. There has to be some simulation that has even been done in cases of pediatric patients. So that is a subset that is different from adults.
Absolutely.
And cooperativeness is something which is much more needed in pediatric patients compared to the adult.
Absolutely. Actually, in fact, it's as you have rightly said, cooperation from the patient is the most important factor which decides the success of this awake anatomy. And you have some case reports in the literature highlighting pediatric age groups also, like you yourself mentioned 9 years old was you have seen. Even there's in the literature we have from 8 years old, and recently 2 years back we also did one patient in pediatric age group which was 5 years 7 months old at AIMS Delhi. So pediatric patients has been operated under awake anatomy, but more important is their psychological maturity. That is very important. You know, even an adult patient may be afraid of going for surgery under awake because it's something which creates anxiousness among this patient. So, as you rightly highlighted, that the role of counseling is very important. Moreover, when it's a usual practice in some centers in, to familiarize the patient before taking for awake anatomy, like taking to the OR, showing them that area so that they do not come to a very unknown place right when you're going for it. Secondly, they are told about what are the different noises they are going to uh, see, or what are they have to hear in that. Many times there are multiple counseling sessions, as you said, showing videos of the previous awake anatomies, so they get familiar what they're going to see. So all these are the things which are actually practiced to make the patient more comfortable during the awake anatomies, and same goes with the pediatric patient as well. So the patient we had was actually for over 6 months, that or even more, that patient was motivated. And probably that, as you know, every patient is different. The girl was quite motivated, and though we were anxious, she was more calm. So, but somehow we could do it very comfortably. So pediatric age group, we cannot define some particular age beyond which we can do. No, it's more of a yes, psychological maturity, which matters a lot. Uh,
We have more questions. Yeah.
okay, we have more, so we can take it, ma'am.
Dr. Priyanka has asked, can awake craniotomy be done in semi-lateral position or temporoparietal craniotomy? That's what she meant. Dr. Ashish can take this question.
Hello.
Okay.
Am I audible?
Yes, you are, Dr. Ashish, yes.
Yes, it can be done. Can be done in lateral position,
Yes, it can
even
be
in
done. If
prone position and a sitting position. The awake craniotomies are done. So it can be done in lateral position also.
And she's asking about how do we place the BIS electrode after giving the block?
Pardon?
When do we place the BIS electrode? Before giving the block or after giving the block? Because the location is the shared location, na? At the time
Giving
of
the block, ma'am. After giving.
Yes, that's very understood actually. After you give the block and then you place the BIS sensor.
Yes, ma'am.
Okay, should we sedate the patient before giving the block or later?
Mild sedation. Mild sedation is started before giving block, and we give paracetamol and then dexmedetomidine and then we place block,
Okay.
and then patient BIS is applied.
Yeah. May I just add upon it? It's like
Please.
we have to work in tandem. What we usually practice is we start off with the loading dose of dexmedetomidine that is to be infused over a period of 10 to 15 minutes. And maybe once a shot of paracetamol has been given, we start administering the block. So by the time the loading dose of dexmedetomidine has been infused, that is the time by which the block has been placed. And maybe another 10-15 minutes or so is the time which we allow the block to settle before we start placing the head on the clamps. So that is where I think a smooth transition occurs. So it's not that uncomfortable for the patient. Yeah, having said that, multiple pinpricks, patient has to be cooperative and has to be counseled well. But if we follow this pattern or this sequence of event, then the transition is smooth and relatively comfortable for the patient.
Okay. All right. One more thing. We should be very careful with the size of the needle, which anybody is actually, but yes, especially the front of the forehead. At
Yes,
the posterior aspect, you might need a thicker needle, but
thicker needle.
yeah,
That's
that
so
also helps.
we usually use a 26 gauge needle for the supratrochlear, supraorbital, zygomaticotemporal, and auriculotemporal nerve. But scalp being a very thick area, we require 23 gauge needle for
Hmm.
placement of that.
Okay, great. Um,
If I can add one
yes,
more,
please.
just yeah.
Uh-huh.
Uh, regarding position, which Dr. Priyanka has asked. Yes, Dr. Kannaujia has mentioned that you can do it in any position, absolutely. Only thing you have to be, because patient remains awake, you need to make the patient comfortable. Whatever position you use, the patient should remain comfortable. So, and most of the time these surgeries are done with supine with head turn to either side, depending on the
Side.
location of tumor. Sitting or semi-sitting position is fine. Prone position for long time, patient may not be very comfortable. So if that's a very short surgery for not and for long duration surgery, then we can even do that. But most of the time we have to be careful about the position regarding patient is comfortable. And regarding BIS electrode, yes, because you share the common area, you cannot use the BIS before putting the blocks. And actually, you need these BIS values or entropy values when you are keeping the patient sedated during the early and late phase and keeping the patient awake during monitoring. So that time is the usefulness of these. So these BIS it's not required during placement of your blocks. So we do it after that. Second, and sedation, as everyone has mentioned, when you're doing any procedures, some amount of sedation would add comfort to the patient. So yes, we start some loading doses, and once the patient is sedated mildly, they tolerate your blocks better. So that is done, and then you can maintain your sedation levels based on your BIS. So this is what everyone has said. So I think there's no confusion in that. Any more question, ma'am?
No more questions.
No more. Okay.
Um,
One more question, if
okay.
anyone can answer. We are short. We are still having time. That's I thought we can discuss more. Brain swelling intraoperatively. That sometimes happens. You know, uh, if there is a brain swelling intraoperatively, surgeon is telling. So that becomes a little situation where we as an anesthesiologist have to do something. So in awake, when sometimes it's because of over sedation, as we said. So we can reduce sedation, and this building up of carbon dioxide can cause swelling. So, and if the patient is awake, we can even ask patient to hyperventilate, ask them to take some deep breaths and all. That will actually cause washing out of
Right.
CO2 and reduce the brain swelling. That can be done. Uh, Caesars, they have already talked, putting, cold saline, which is very important. And everyone has highlighted it. These are some of the important complications which do happen, and we have to troubleshoot them. And it's very important that you should give midazolam to control rather than giving long-acting drugs like, uh, Levera or this, because again, they will interfere with your uh, picking up of your Caesar sites. Uh, these are some important things for a patient intraoperatively, which we have to brain swelling, air, and if suppose the patient is over sedated or some complication occurs, like seizures is not being terminated, then you might have to even go for intubate the patient or turn this awake anatomy into a journal. And so, yes. So these are things we have to be prepared. So whenever we are taken awake, but patient awake anatomy, but we have to be prepared for any catastrophe which can happen intraoperatively. Absolutely. So I think that was good. Any other questions, if ma'am, you want to take on? We have one more. How to awaken patient if BIS is around 75 till patient is not responding to commands. Okay, patient is not responding to commands, BIS is around 75. You have to just wait for, reduce your sedation and wait for the
There's not
time.
much you can do about it,
Yeah,
except
has to be,
waiting that the risk
yes, you have to
rises.
give some time for the patient to get more awakened and start responding to your commands. And then you have to do the neuromonitoring, because patient has to cooperate while doing the, that's the purpose of having an awakening. So only thing you can do is wait for some time till the patients start responding to command. So if no more question, can we close the session, ma'am?
Rachna, any comments? So if there are no more questions, Dr. GP Singh, then I'll propose the vote of thanks. Am I right? Can I?
Yes, ma'am. Thank you so much.
Good evening, everybody. Sorry, I
evening.
joined
Good
late.
evening.
I was there for the ISA Delhi clinical meeting, so I got late. So this is the first time that I joined late. Thank you very much for the excellent webinar we had today and such a lively discussion. Really, it was so interesting, and we learned a lot. Awake craniotomy with scalp block definitely is an art. You know, we all do, of course, the scientific part, but the art is very important. And hearing the experts, Dr. GP Singh and the others who gave excellent lectures, and Rachna also, we have seen how we can sail through. So it's not an easy task, but we can sail through these procedures with expertise. So thank you so much, Dr. Rudrashish, Ashish and Sumit for those lovely lectures. And Dr. GP Singh, thank you so much, seeing you after a long time. And Rachna for the excellent moderation. Thank you so much.
Thank you, ma'am.
you, ma'am.
Thank you, ma'am.
Thank you,
Thank
Swastika.
you.
So we'll
Thank you,
meet
ma'am.
next Wednesday. We'll meet on Wednesday. Thank you very much.
Thank you, ma'am.
Good night.
Good night, ma'am.
Good night, everybody. Good night.
Thank you so much to everyone. And Clarinet is really glad to have all these brilliant people together in this session today. And thank you so much for giving us this opportunity to host the session. And I hope you all had a seamless experience. So with everyone's permission, I'm covering the session in airport today and looking forward to host you again. Thank you so much.
Good night.
Thank you.
Thank you.
Good night.
Good night.